The American Brain Tumor Association is pleased to welcome you back to our webinar series. Today's webinar is titled High-Grade Gliomas, What's New? Please note that all lines during our webinar today are muted. If you have a question you would like to ask, type and submit it using the question box in the control panel on the right-hand side of your screen. Dr. Chamoun will answer questions at the end of his presentation. In the next few days, you will receive an email asking you to take a brief survey to evaluate this webinar. Please take a few minutes to share your feedback, which is important to us as we plan for future webinars. Today's webinar is being recorded. The recording will post to the ABTA's website on the webinars page shortly. Registered participants will receive the webinar recording link in a follow-up email message tomorrow. Our webinar today will be discussing high-grade gliomas, what's new? My name is Christine Daly, Program Manager here at the American Brain Tumor Association. I'm delighted to introduce our speaker today, Dr. Roukoz Chamoun. Dr. Chamoun is a board-certified and fellowship-trained neurosurgeon with the University of Kansas Health System. Dr. Chamoun's clinical practice is focused on brain tumors, skull-based surgery, cerebrovascular surgery, pituitary surgery, and aneurysms. Dr. Chamoun's specialties include neurosurgery, adult, aneurysm surgery, cerebrovascular surgery, and endoscopic surgery. Thank you for joining us, Dr. Chamoun. You may now begin your presentation.
Good afternoon, everyone. So today in the next hour or so in this webinar, I'll be talking about high-grade gliomas. So high-grade gliomas are essentially two kinds of tumor. It's the glioblastoma or GBM and anaplastic astrocytomas. So today I'll be talking about these tumors. We will start by giving a little bit of basic information and basic introduction on these tumors. Then we will talk about the treatment options, and outcome and prognosis. As a surgeon, I will focus mostly on advances in the surgical treatment. So we will talk a little bit in details about the surgery, surgical options, and what are the technologies available to the surgeon to make the surgery safer and more effective and efficient. I will not be discussing in detail the chemotherapy options and radiation therapy options because this is not really my area of expertise. Now, in addition, this presentation will mostly include treatments that are standard of care and that are FDA approved. In addition to that, every patient with glioblastoma or anaplastic astrocytoma, at some point in their treatment, they will be faced with the option of being included maybe in a clinical trial or some form of experimental treatment. The discussion of a clinical trial or experimental treatment, this is a very vast topic by itself. It will probably take an hour or a separate webinar. So we will not go into any details regarding this kind of treatment. Usually clinical trials, they include some form of new treatment or new medication, maybe a vaccine or virus injection. But again, these are not FDA approved, and they are still going to be part of investigation until being approved, hopefully in the future. As a disclosure, I don't have any disclosure. I don't have any conflict of interest. So let's talk a little bit about the different types of brain tumors. The patient usually gets the diagnosis of a brain tumor from primary care physician, sometimes maybe in the emergency room after a visit to the ER, maybe for headache or after trauma or maybe a seizure. And then somebody will tell the patient that you have a brain tumor. When I see these patients in the clinic, usually there's a lot of confusion, a lot of questions. People don't know what to expect, and it's it's a little bit intimidating to have a tumor. The reality is that at the end of my visit with the patient, a lot of things can happen, right? So sometimes the tumor can be very small, can be a complete incidental finding, can be benign, and the patient will leave the clinic with the understanding that they will go on with their life, and practically there will be no effect whatsoever of that tumor on the life of the patient. On the other hand, a different diagnosis, such as a glioblastoma or anaplastic astrocytoma, it's a very serious diagnosis. And from that moment on, the patient will start on a journey basically to fight this tumor. This will include surgery, radiation, chemotherapy, and the whole focus of the patient and a lot of resources from the patient and the family will be targeted toward the treatment of that tumor from that moment on. So brain tumors in general, this is a very vast diagnosis, and different tumors can be very different. So when we talk about brain tumor, it's important to differentiate what kind of tumor we're talking about. Is it primary or secondary tumor? A primary tumor is a tumor that will start in the brain tissue itself. Secondary tumor is a tumor that will start somewhere in the body and then spreads to the brain, such as lung cancer or breast cancer with metastasis to the brain. And then every tumor, it's important to know if it's benign or malignant. A benign tumor is a tumor that will grow slowly over time, and usually if it's small, it wouldn't cause any problem. A malignant tumor, on the other hand, is a fast-growing tumor, and it's a tumor that can put the life of the patient at risk, and it has the potential for spread. Now, malignant brain tumors such as GBM, typically they do not spread outside the head. They don't go outside the head. They can, but this is very rare. But they can spread within the spinal fluid, so basically extend from one area of the brain to the other, and they can also spread to the spinal cord. Now, again, tumors, they can be different, so we have different types or different kinds of tumor, and that will depend on the cell of origin of the tumor. So a meningioma would be very different from a glioma or schwannoma or epidemioma, so these are different types of tumors. And finally, we have to look at the grade of the tumor. The higher the grade, usually it means that the cells, they look more abnormal and the tumor is much more aggressive. Grade 4 is the highest grade for a brain tumor. So every time we're faced with a tumor, we have to look at these characteristics. Is it primary or not, benign, malignant, what kind, what type, and what grade? So let's talk a little bit about glioblastoma or GBM. So GBM is a primary brain tumor. It starts in the brain tissue, it doesn't come from anywhere else. It is malignant. This is a very aggressive tumor and very deadly tumor. It is a glioma. This is the kind of the tumor, the type, and it is a grade 4, which is the highest grade of a brain tumor. Now, GBM, they have two subtypes. The first subtype is a de novo GBM. The de novo GBM basically means that the tumor will start up front as a glioblastoma. We have a number of patients where at some point in their life, the MRI can be completely normal, patient is fine, and then later on, maybe a few years later, another MRI is done, and you see a glioblastoma. So this is a tumor that started up front as a glioblastoma. We call them de novo GBM, and this is actually by far the most common subtype of GBM, roughly 80% of GBM. This type will occur in older patients, mean age roughly 64 or 65%. For this tumor, there are certain typical genetic pattern. So these are certain genes that we expect for this kind of tumor. I'm not going to go into details into this area, but it's important to know that there is a certain genetic pattern for these tumors. The other subtype is a GBM that will progress from a lower grade tumor. So here in this case, the tumor will start as a lower grade, maybe grade 2 or a grade 3 tumor, and eventually over time, it will progress or degenerate into a higher grade tumor, into a GBM or grade 4. These tumors, they tend to occur in younger patients, the mean age roughly 45%, and they tend to have a little bit different genetic patterns, so the different genes and chromosomes for these tumors. Now, we said that GBM is a very aggressive tumor. It's a grade 4, the highest grade tumor. And unfortunately, not only it is the most aggressive, it is also the most common malignant primary brain tumor. If you look at all gliomas, including low grade and high grade, roughly 54% of these gliomas will end up being a GBM. And if you look at all primary brain tumors, roughly 16% are GBM. So this is a very common tumor, and it is very aggressive. The average incidence per year in the United States will be roughly 3 patients per 100,000 persons. If you look at large series with the incidence of GBM, it is slightly more frequent in males, but clinically we obviously see them in males and females. Now, let's talk about the prognosis. So how aggressive this tumor is. Well, it's a very aggressive tumor. The prognosis in general is not very good. The median survival after the diagnosis of a GBM is roughly 15 to 18 months. So this is a very serious, deadly disease. Obviously, when we say median survival of 15 to 18 months, it doesn't mean that every single patient is going to live exactly 15 to 18 months. But what it means is that certain patients, they will live longer than this. They will have much better outcome, but other patients will have much worse outcome. And then if you do your statistics and averages, you'll end up with a number roughly around 15 to 18 months. Now, even though this is technically the same tumor, we call them all GBM, but some patients, they do so much better and they tend to respond to the treatment, and other patients, unfortunately, they do so poorly, and the treatment just does not, the tumor does not respond to the treatment. So in reality, GBM is a very heterogeneous group of tumors. There are a lot of subtypes within the GBM based on the genetic alterations of these tumors. So at the end of the day, when you look at all these different genetic alterations, the prognosis and the response of the tumor to the treatment can be greatly affected by all this. And this is how we can have one GBM that is very aggressive, doesn't respond to the treatment. On the other hand, we can have another patient with a GBM with fairly reasonable and good response to the treatment. Now, what are the other important prognostic factors? So if we take a patient with a GBM and we're trying to project and try to guess if the outcome is going to be good or bad, and what are the factors that will affect the outcome? Well, we said that the genetic aspect of the tumor is very important. Obviously, this is number one. The tumor size, location, they are very important. Whether the tumor has one focus or multiple foci, multifocality of the tumor. And then you have the age of the patient, comorbidities, the functional status of the patient, if the patient is functional or not. So all these are very important factors. Now, when you look at the whole list, it's obvious that for a lot of these factors, we really can't affect them. These are not modifiable factors. The treating physician and the patient, you really can't do anything about it. Like genetic alteration of the tumors, we can't really change that. The age of the patient, comorbidity, whether the tumor is multifocal or not. So a lot of these factors are not, we can't really modify them, except for one important exception is going to be the surgery, resectability of the tumor. So you see that this is one factor that can be affected by the surgeon. If the surgeon is able to remove the tumor and achieve an aggressive surgery leading to a subtotal or maybe gross total resection, this will have significant positive impact on the prognosis and the outcome of the patient. On the other hand, if we cannot do an aggressive surgery and remove big part of the tumor, then this will have significant negative impact. And this is why the tumor resection is one of the most important factors, because this is the one factor that we have control over. Now, let's talk a little bit about anaplastic astrocytoma. Anaplastic astrocytoma is also similar to GBM. It's a primary brain tumor. It is malignant brain tumor. This is also a glioma. This is so same kind, same type of tumor, but this is a grade 3. So this is a little bit less aggressive than a glioblastoma. The median age, these patients tend to be younger. 41 years of age. And similar to GBM, some of the anaplastic astrocytoma, they appear de novo, anaplastic astrocytoma. They start as such. And other anaplastic astrocytoma, they will start as a lower grade tumor, as grade 2, and then eventually will progress to grade 3. Now, unlike GBM, we said that GBM, most of them by far, 80%, they are de novo GBM. Here in anaplastic astrocytoma, most of them, 75% of them at least, they start by being lower grade tumor, and then they progress and degenerate into an anaplastic astrocytoma. Now, anaplastic astrocytoma, again, it's a grade 3 tumor. It is less common than GBM. If you look at all gliomas, while GBM was 54%, this one is roughly 10%. The prognosis is also a little bit better because this is a grade 3 tumor, not grade 4. The median survival is roughly 3 years, and 5-year survival is roughly 28%. But again, similar to GBM, these are very heterogeneous tumors, and we know that different patients with anaplastic astrocytoma, they can have complete different outcome based on a number of factors, including the genetic aspect of the tumor, age, comorbidity, and whether the tumor can be removed or not. So this was discussion about basic understanding of these tumors. Let's move a little bit to the treatment. So how are we going to treat patients with glioblastoma and anaplastic astrocytoma? The aim of the treatment is to try to improve survival and to preserve and improve the quality of life. So survival and quality of life, these are the two big factors. Now, in order to achieve that, this is a multidisciplinary approach. Patients with glioblastoma and anaplastic astrocytoma should be treated by a team, and that team will definitely include a neurosurgeon, because surgery, this is usually the most important initial step. And after surgery, this is followed by radiation and chemotherapy, and then after that, maintenance chemotherapy. So these are the standard steps. This is the standard of care: maximal safe resection, followed by radiation and chemotherapy, and then maintenance chemotherapy. Now, for the surgery, maximal resection, because if you can achieve subtotal or gross total resection, this will definitely give the patient significant benefit and advantage in terms of survival and improving outcome. However, surgery has to be safe, obviously, and complete resection is not always possible. And the surgeon really needs to try to avoid any major complication, because if you end up with a major complication and significant neurologic deficit, that will probably offset any potential benefit from the surgery. So let's talk a little bit in detail about the surgery, role of surgery, and what are the options and technologies available for the surgeon. So the surgery is a crucial initial step in the treatment of GBM and anaplastic astrocytoma. There are a number of goals for the surgery. So remember, the patient initially will present typically with an MRI, and at that point, glioblastoma is still a suspicion. We're looking at the MRI and we're suspecting that probably the patient has a glioblastoma or an anaplastic astrocytoma. So the surgery will be done. One of the goals of surgery will be to remove the tumor, send it to the pathology, and to establish that as a clear diagnosis. So basically to confirm the diagnosis and to study all the genes of the tumor and get a sense of really the kind, the type of the tumor, and the genetic aspect of the tumor. So this will be the first step. The second goal of the surgery will be to achieve a maximal resection in order to give the patient that potential survival benefit and improve the outcome. On the other hand, surgery has to be safe, and we have to try to limit or minimize the risk of any major neurologic deficit. Sometimes the goal of surgery will be decompression and relieving mass effect. occasionally, the tumor can be big and put pressure on critical structures of the brain, leading to certain symptoms. And when you remove the tumor, this will relieve the pressure and improve the symptoms and quality of life of the patient. Now, we mentioned obviously the importance of the surgery. Surgery is very important because this is one of the strong predictors of better outcome and increased survival. And this is one of the major modifiable risk factors. So this is a risk factor that we can intervene on and we can modify. However, it's important to understand that surgery is not curative. We cannot cure GBM by surgery. Surgery is one step in the treatment. It has to be followed by adjuvant treatment, by radiation and chemotherapy, and continuous follow-up after that. So this is an example. Let me show an MRI of a classic typical GBM. So this is how it looks like. This is an MRI of the brain with contrast. The tumor typically has a necrotic center. It looks black here. And then with the contrast, there is enhancement around it. So this is a classic appearance of a GBM. This is after surgery. So surgery was done in this case. We call this a gross total resection, when you can remove everything that is enhancing. So the enhancing part of the tumor and the necrotic part of the tumor are removed. And then you see a surgical cavity here. So this is called gross total resection. Again, this does not mean cure of the tumor, but this is a very important and a crucial initial step in the treatment. This is another example. You see here in this case, this patient had two foci. So the patient presented up front with a multifocal GBM. You see this is one focus of the tumor in the back, and then on this cut, you see another focus of the same tumor. So this is a multifocal tumor. Now, for a multifocal GBM, the treatment can be a little bit tricky. It has to be discussed on a case-by-case basis. Sometimes the decision is to proceed only with biopsy, with no surgery. Sometimes the decision would be to remove only the big tumor, but leave the smaller tumors behind, and then start radiation and chemotherapy. So every case is a little bit different. In this case, we felt that these two foci, both of them can be removed safely by surgery. So this is what we did. We did basically a combined surgery. This one was removed and that one was removed, achieving that aggressive surgery and gross total resection that we were talking about, trying to give the patient the benefit of an aggressive treatment for better outcome and survival. So we talked about the importance of an aggressive surgery and maximal removal of the tumor, obviously, but you always have to remember that this is not always possible. The aggressive tumor removal has to be balanced against the preservation of function and the possibility of a major neurologic deficit. Sometimes these tumors can be located in an eloquent brain area. So these are areas controlling very important brain function, and then surgery can be extremely risky, and the potential for complication is high. So the surgeon will be faced with this dilemma. An aggressive surgery will give the patient survival benefit, but we really need to try to prevent complications. So nowadays, there are a number of adjunct and a number of technologies available for the surgeon to use during surgery, trying to push the limit, remove as much as possible from the tumor while minimizing the risk of major deficit. Now, let's take a look a little bit about, take a look at what constitutes an eloquent brain area. When you look at the brain, there are certain parts of the brain that are known to be eloquent because they control very important and critical function of the brain, such as motor function or sensation. So this, for example, is the part of the brain controlling movement of the hand and leg. So if the tumor is located close to these areas, this is when it becomes tricky and the surgery can be more dangerous than average. These are areas controlling speech, for example, and language. This is the visual cortex. So these are called eloquent brain areas. The surgeon knows in general the location of these areas, and if the tumor is close enough, this will take the complexity of the surgery to a whole new level. this is an example how we use technology in general to see how close is the tumor to these critical structures. So in this picture here, you see the MRI showing the tumor. You see the tumor in multiple cuts here, and then these are the fibers coming from the motor cortex. So the cortex here controls movement of the arm and leg, and these are the fiber tracts going from the brain into the spinal cord, eventually into the arm and leg to command movement. So here in this view, we're trying to understand how close the tumor is to these critical structures in order to plan a surgery to remove the tumor while preserving all these functions. Now, as I said, if you can perform surgery and be aggressive with the surgery and proceed with gross total or subtotal resection, it definitely has to be done. However, this is not always possible, and sometimes we go for just a simple biopsy. So the purpose of the biopsy will be just to basically confirm the diagnosis, prove the diagnosis, and start radiation and chemotherapy. So when would we do that? Well, sometimes it's because the patient is not a good candidate for a big surgery. It can be the age or comorbidity, or patient is just too sick or too ill for surgery. Sometimes it's because of the tumor. The tumor can be considered unresectable, maybe because of the size of the tumor, or maybe because of the bad location of the tumor. So this is an example of a patient where we did just a simple biopsy. You see this is a very aggressive tumor. It's extending to both sides of the brain, the right and left hemisphere. It's involving a very critical structure here in the brain called hypothalamus. So if the surgeon attempts an aggressive surgery in this area, potentially the patient will end up with a very severe neurologic deficit and a devastating neurologic outcome. So this will potentially offset, obviously, any benefit from the surgery. So in this case, we just did the biopsy and then radiation and chemotherapy. So let's go back to a surgery where the plan is to achieve a gross total or maybe a subtotal resection. So here we're trying to push the limit. What are the tools available for the surgeon to improve the outcome, push the limit of the surgery, and minimize the risk of the surgery? One tool available is the functional MRI. So functional MRI is a special kind of MRI basically used to localize a brain function. So we typically know roughly where the language and motor function and sensory function are in general when we look at the regular MRI, but the functional MRI will tell us practically exactly where these functions are for a specific patient. So in this case, the patient will be in the MRI machine. The patient will be asked to perform a certain task, such as speak or move the right hand or move the left foot. So perform a certain task. During the task, there will be an increase in the blood flow to that part of the brain that's being activated during that task. And this increase in the blood flow and activation of cortical areas will translate into a change in the oxygenation of the hemoglobin, and that will result in an increased signal in the MRI, and the MRI machine will detect that. So this is how we'll be able to tell that this part of the brain, for example, was responsible for the movement of the left leg or right arm or any specific function. So let's take a look at an example. This is an example of a patient with a tumor here. This is a basic MRI, and based on this MRI, we suspected that the tumor is very close to the motor cortex, the part of the brain controlling movement, specifically of the left hand. So we did a functional MRI, and you see this signal here. This is exactly the spot, the location of the part of the brain that's controlling movement of the hand. So now we know the part of the brain controlling hand movement, and we see the tumor, and then we see how close the tumor is to that part of the brain. And if you're planning for surgery, definitely a big part of the surgical planning will be to protect this part and avoid any paralysis or severe weakness while removing the tumor. So in this case, so this is the surgery was done. This is after surgery, and the tumor we were able to remove the tumor while protecting the motor function. Another important tool available for the surgeon is the awake craniotomy with cortical mapping. This is something that's extremely important. So in this case, we have the patient awake during surgery, and there are a lot of advantages for that. Number one, since the patient is awake, after exposure of the brain, we can apply a little bit of electric stimulation on the surface of the brain, and this will allow the surgeon to determine exactly what are the critical parts of the brain. So if we stimulate, let's say, this part and the right hand of the patient jumps, then we know that this is the part of the brain controlling movement of the right hand, and then surgery should be done while protecting at any cost this part because it's critical to the function. So this will be the first part of the surgery, try to determine the eloquent areas of the brain. After that, tumor resection will start, and during removal of the tumor, the patient is awake and is being monitored on a regular basis. So all the time we ask the patient to move the head, move the arm, speak, talk, we interact with the patient, and this way we are sure that while removing the tumor, the patient is still doing fine with no major deficit. So awake craniotomy is obviously one of the major tools to push the limit and optimize surgery and resection while minimizing risk of deficit. What are other tools available? 5-ALA is a new drug that is that's very important. In June 2017, it was FDA approved. So 5-ALA is an optical agent. Basically, what it is, it's a drug that will allow us to better visualize the tumor. So we'll be able to see the tumor better during surgery. This drug is given to the patient orally before the surgery. It will, after the patient takes the drug eventually is absorbed into the body. Eventually, it will go to the tumor. It's metabolized in the tumor and transformed into another molecule, protoporphyrin 9, which is a photosensitive molecule. So then at that point, when you use a special light on the microscope, we call it the blue light excitation, then the tumor tissue will turn red, and you'll be able to differentiate what's tumor and what's not. Now, let's think about it a little bit. So traditional surgery without fluorescence is done with a regular white light. So the surgeon will look at the tumor directly or maybe under the microscope. In this case, the surgeon really is relying on his experience and maybe the color of the tumor, consistency of the tumor, and how it looks like, trying to differentiate what's tumor, what's not. And sometimes it can be very confusing. So certain areas of the brain can be very confusing, whether they are infiltrated by tumors or not. And this is where the experience of the surgeon plays a major role. With fluorescence-guided surgery, if you use 5-ALA, then you can switch from a regular white light to the blue light, and then at that point, the tumor cells will look red, and the brain will stay blue. And in this case, you can tell, easily what's tumor, what's not. And then it's still up to the surgeon to decide whether removing the spot is safe or not. So the 5-ALA is not going to tell you if it's safe to remove it, but it will tell you where the tumor is, and then the surgeon will have to decide if it's safe to remove it or not. So this is obviously something very important. Again, it was FDA approved in 2017 in the US. Other tools available for the surgeon, the intraoperative MRI, another very important tool. So here in this case, the surgeon will perform the surgery and again try to remove maximum of the tumor, and then at some point the surgeon will stop and feel that, well, I did what I can and it looks good. Instead of finishing the surgery at that point, and the patient will be sent to the ICU and wait for the MRI next day, in this case the MRI can be done during the operation. So you finish the surgery, you do an MRI right there, and this will allow the surgeon to reassess and look again and assess the result of the surgery immediately. Now, if the surgeon sees some additional tumor that can be removed safely, then you're still in the operating room. He can perform more and really push the limit of the surgery. So this is an example of a case that we did in the intraoperative MRI. So look at this tumor. This is a tumor on the temporal lobe. So the patient was taken to the operating room. We did the surgery, and at some point, it looked good. I was fairly satisfied with the surgery. I felt that we achieved the goal of the surgery. So we did an MRI at that point, and then looking at the MRI, I realized that still there was a piece of the tumor that I still can remove. And in my judgment, this was not a very dangerous piece, so the risk of removing it was not excessive, and this potentially can help the patient and improve the outcome. So since we are still in the operating room, additional removal was done, and then the final result was certainly much better. Another topic to talk about is brachytherapy. So as I said before, the treatment of GBM is usually surgery followed by radiation and chemotherapy. And when we say radiation, typically we mean an external beam radiation. This is when there is a big machine that will give you a radiation. The radiation will have to go through the skin, the skull, and the brain, and eventually hit the target. So that's conventional radiation. Brachytherapy is a little bit different. This is a type of internal radiation. This is when seeds containing radiation source are placed in the surgical cavity during surgery. So this potentially has significant advantages, obviously. So potential advantages are that radiation is delivered directly to the targeted area. We're just placing the radiation directly where we want it to be. And then there will be minimal radiation to all the normal structures and the brain and the skin. So potentially this will limit significantly the side effect. Another advantage is that usually when you do surgery, you have to wait for the healing process, and then radiation can start in general 2 to 3 weeks or 4 weeks after surgery. In this case, with brachytherapy, you're eliminating all the delay. You do the surgery and radiation at the same time, so there is really no delay between surgery and radiation. So all these are potential advantages for brachytherapy. Now, when it comes to GBM and Anaplastic Astrocytoma, this form of treatment, brachytherapy, at this point is FDA approved for recurrent brain tumor. So in July 2019, gamma-tile therapy was FDA approved for recurrent tumors, which means that still the standard of care for a newly diagnosed tumor, it's still the conventional radiation. So you do the surgery first, you recover, and then you start radiation and chemotherapy together after a few weeks. But if the tumor has recurrence and you're planning for another surgery, this is when you can go with the gamma-tile and proceed with brachytherapy. So the second surgery can be done with radiation at the same time. This is a picture of the gamma-tile. So gamma-tile is essentially it's a tile, it's a collagen tile, and inside these tiles we have cesium seeds, and these small seeds, they are the source of radiation. Finally, I want to talk a little bit about laser ablation therapy. So laser ablation is again, relatively new treatment modality. It's a very important tool and option for certain patients. In general, it's considered as an alternative to removing the tumor. So in this case, if we're applying laser, we're not really doing surgery to remove the tumor. In this case, there is insertion of a laser tip probe into the tumor. After we place the probe into the tumor, we deliver the laser, which is essentially a controlled thermal injury. So it's a heat injury of the tissue, trying essentially to burn the tumor. All this is done in the MRI under strict monitoring of the temperature of the normal brain and the tumor. So this can be done in a very, very precise way, trying to deliver heat injury only to the tumor while protecting the rest of the brain. Now, again, this is a relatively new treatment modality, and because it's new, the outcome information and data is a little bit limited. impossible to compare it to surgery at this point. So I would say that whenever surgery to remove the tumor is possible, I personally still prefer that. And I think this is still the gold standard and the standard of care. However, if surgery is not possible, this is a very appealing option. So in certain cases, the tumor is very deep and it will be very dangerous to remove it by surgery, then laser ablation is a very, very appealing option. Or maybe the patient is not a good candidate for surgery, older patient, a lot of comorbidities, then laser ablation can be done. It's minimally invasive. Patients will stay in the hospital overnight, typically one day, and then they go home next day. And this potentially can be, as effective as surgery. Again, as long as surgery is not a good option. This is an example of a patient where we decided to proceed with laser. So you see the tumor here and the planning to put the laser probe inside the tumor, and then we deliver the laser. The temperature of the normal brain is being monitored continuously, and then there will be heat injury to the tumor. So I will conclude with that, and I'm happy to take any questions.
Thank you, Dr. Chamoun. We will now take questions. If you have a question you would like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of your screen. If we are not able to get to all of the questions, I will be able to answer them after the webinar. One of the first questions that we have for today, and again, Dr. Chamoun, if you want to answer these questions at a later time, please just let me know and we can follow up after the webinar. Our first question is asking you to actually talk a bit more about the brachytherapy and how it works, specifically talking about side effects and whether or not those side effects are any different from radiation post-surgery.
Right. So in terms of side effects, usually brachytherapy has less side effects because, again, you're giving radiation directly to the target. This is very precise, and there will be minimal radiation to normal brain tissue. So potentially the side effects are significantly less than traditional radiation. Now, the problem is that with glioblastoma or anaplastic astrocytoma, sometimes the tumor is so extensive that you really want to give a little bit more radiation. You don't want to be very precise initially. So this is why the standard of care for an initial treatment, if the tumor is newly diagnosed, will be the traditional surgery followed by radiation and chemotherapy. When you reach a stage where the tumor is growing back, typically traditional radiation, regular radiation, is not an option anymore. Once you get radiation, you cannot get more radiation because now you're going to have much more side effects from regular radiation and minimal benefit. But you still can get brachytherapy. So this is what's appealing about it. So for a newly diagnosed tumor, this is not a good option and it would not be approved. It's still got to be surgery followed by radiation and chemotherapy. And then at recurrence, the patient anyways cannot get traditional radiation most of the time, but you can do another surgery followed by brachytherapy, and this is a great option as a salvage and backup plan. Now, for different kind of disease, let's say metastasis or different kind of tumors, yes, brachytherapy can be performed upfront for a newly diagnosed metastasis, but that's a completely separate topic. These are very different than glioblastoma or anaplastic astrocytoma.
Thank you. Our next question is, do you have any opinions or more information about using gamma knife for treatment?
Right. So gamma knife is a form of radiation. Gamma knife is usually very precise form of radiation. Again, I would say that the standard of care for an initial, a newly diagnosed tumor will not be gamma knife. If you have a newly diagnosed GBM, you don't want to be that precise because the tumor usually extends way beyond what you see on the MRI. So you want to be as inclusive as possible. So surgery followed by traditional regular radiation and chemotherapy is the way to go. Now, For recurrence, if there is a spot of recurrence, if it's very small and precise, and the patient cannot get additional regular radiation, then yes, gamma knife may be an option. But this is not a good option for a newly diagnosed GBM for sure.
Great, thank you. There's also a question about gliadel wafers and whether or not they have a place in treatment and what the dangers are.
Yeah, so this is a very good question. So gliadel wafer, essentially, it's a chemotherapy. These are chemotherapy wafers that are placed during surgery. So you remove the tumor, and similar to brachytherapy, instead of putting radiation seeds, in this case, you're putting a chemotherapy wafers, and then you're delivering chemotherapy directly in the surgical site. Now, studies were done on gliadel wafer, and gliadel is FDA approved. Studies have shown that there is some benefit. They tend to increase survival a little bit, so there is some benefit, and this is why they are FDA approved. The problem is there is potentially there are significant side effects. Potentially brain edema and swelling can be significant and can be impressive. A lot of seizures and a significant increase in wound problem and wound healing. So it's a balance between potentially a small benefit and potentially significant side effects. Another problem with gliadel wafer is that a lot of clinical trials are excluding patients who received gliadel wafer. So if the patient wants to be included at some point with a new clinical trial, something that looks promising, some virus injection or vaccine or something like this, not all of them, but a lot of them are excluding patients who previously had a gliadel wafer. So I would say that today, the way it is now, gliadel wafer are FDA approved for sure. They are being used in some places, but I would say that most places, they are shying away from using them because of all these factors. Limited benefit, potentially a lot of side effects, and potential exclusion from certain important clinical trials.
Thank you. Our next question is about anaplastic oligo, asking if the treatments that you mentioned would be beneficial for that type of tumor.
Sure. So anaplastic oligo is another high-grade glioma. So high-grade glioma usually includes any tumor grade 3 or 4. Anaplastic oligo is one of them. Oligodendroglioma are always better. They have better outcome and prognosis compared to astrocytoma, just because of the nature of the tumor, the cell type, and the genetic aspect of these tumors. So the treatment is the same. It's just that the outcome usually is better. The tumor responds better to chemotherapy, usually, mostly, but also to radiation. So the treatment is the same, but the outcome is usually better.
Thank you. We've gotten a couple of questions about tumor treating fields. Could you talk about them a bit more, or any recommendations for someone that may be considering tumor treating fields for GBM treatment?
Yeah, this is really outside my area of expertise. So this is becoming an option usually discussed with the oncologist. I'm not gonna go into much detail about that.
No problem. Thank you. Our next question is asking about treatment options for side effects of GBM, specifically musculoskeletal side effects that may impact ADLs, spasticity, and tone of affected extremities. And let me know if you want me to skip over or answer that question later.
Yeah, I mean, that's usually, it has to be a discussion with the neurologist or the oncologist. It depends. It's a very wide question, and it has a lot of ramifications.
Thank you. Our next question, has MRI-guided LINAC been used for treatment of GBM, and has it helped?
So LINAC is essentially similar to gamma knife, which is a radiation therapy. So my answer about gammaknife is the same about LINAC.
Okay, thank you. I think that is all the questions that we have today. Thank you all for joining us, and thanks once again to Dr. Chamoun for his wonderful webinar presentation. Besides our free educational webinars, ABTA has a variety of programs available to help connect patients and caregivers with information and resources to help support them in their brain tumor journey, as well as publications and resources for healthcare professionals. For more information, please visit ABTA's website at www.abta.org or call the ABTA care line at 1-800-886-2282. This concludes our webinar. Thank you for joining us. Please be sure to complete the evaluation survey that you will receive by email within the next 2 days. If you have any questions that weren't answered, please email them to info@abta.org, and we'd be happy to answer them there. Thank you. Bye.